So this is Chapter 7, Periodontitis. Periodontitis is the middle section on your chart that we use in clinic that explains what necrotizing periodontal disease is, regular periodontitis, and then periodontitis is a manifestation of a systemic disease. Periodontitis is just going to be the most common one you're going to use. And that's the one we're going to use the staging and grading chart. It's a complex microbial infection that triggers a host-mediated inflammatory response resulting in destruction within the periodontium. So microbial infection that triggers the host response. Basically, plaque and bacteria form around the tooth and the gum. It triggers your body to recognize it and try to fight it with the inflammatory process. And as a result, it causes destruction to the periodontium. And this is a picture of what the supporting periodontium looks like in periodontitis. So characteristics of periodontitis. You may see it referenced as chronic periodontitis, aggressive periodontitis, or localized juvenile. Those are all older terms. Since 2017, when they revised all the classifications, we're trying to move away from those terms, but you will still see those terms commonly out in practice and stuff too. Periodontitis has signs and symptoms. It has an abundance of mature plaque and calculus. The tissue color has probably changed, and there may be some gingival bleeding, loss of attachment, and mobility on the teeth. The patients usually notice that their gums are red, they're swollen, they have bleeding when they brush, they have a bad taste in their mouth, they have bad breath, sensitive teeth, loose teeth, maybe even some pus. Alterations of the color and size, the tissue goes from that nice pink to red. The gingival margins become rolled due to the inflammation and the detachment. The papilla become flattened and the tissue can appear pale pink. Do not rely on the clinical appearance because the appearance may not always be the same. There may not even be a lot of changes in the clinical appearance. So for example, in picture example 1, you can see that's obviously got some clinical appearance changes. But if you look at example 2, there's minimal change in the way the gum tissue looks. That almost looks pink and healthy. But when you look at this gum tissue, the clinical appearance of the tissue suggests it looks healthy. You can see the stippling, it's pink, it's firm, but look what happens when you measure the with a periodontal probe. The bleeding, crevicular fluid, and exudate. Bleeding is common, spontaneous, or in response to instrumentation. So spontaneous might be when you bleed, when you brush or when you just press on it. There's an increased flow of crevicular fluid inside the pocket, and there's pus in the pockets. And so the first picture shows you what bleeding on probing looks like. And the other picture on the right shows you finger pressure on the gingiva that reveals exudate from the gingival tissue. Exudate is pus. And when you have patients that have some more advanced periodontitis, you will be able to see pus when you press it with your finger. Plaque, biofilm, and calculus. It's characterized by supra and subgingival, and then soft and hard. So plaque is soft, calculus is hard. Supragingival, meaning it forms above the gingival margin. Subgingival means that it occurs below the gingival margin. Keep in mind that the gingival margin is the divider in that case, and so if the patient has recession and it's the root surface is exposed, if it's on the root surface above the gingival margin, it's still considered supra. And you can have very thick and complex deposits of plaque, and host factors determine the pathogenesis and rate of progression. What that means is how your body reacts to that plaque and calculus depends on how fast and how advanced the disease becomes. Loss of attachment. We have clinical attachment loss, or abbreviated as CAL. can occur in one site of a single tooth or several teeth or the entire dentition. Clinical attachment loss includes the apical migration of the junctional epithelium to the tooth root. In other words, the junctional epithelium is moving apically on the root of the tooth or on the cementum. The destruction of the fibers of the gingiva, so those gingival fibers that kept the free gingiva attached or close to the tooth, are destroyed. The periodontal ligament fibers are destroyed, and there's loss of alveolar bone support. And there's radiographic evidence of periodontitis in this picture. You can see that the alveolar crest is all the way about 50 to 60% down the root of the tooth. Loss of attachment creates periodontal pockets. So let's talk more about clinical attachment loss. If you look at picture A, you can see that the probe is way down deep in that pocket. If you were to reflect the tissue in that exact same area, you would see this deep pocket. There's no bone on the mesial side of that molar of tooth number 14, and even the furcation has exposure. The distal of 13 has some level of exposure. So clinical attachment loss of 1 to 2 millimeters at one or more sites can be found in almost all members of the adult population. So clinical attachment loss can include recession as well. And clinical attachment loss characteristics are the loss of alveolar bone support, pockets or recession of the gingival margin, furcation involvement, and mobility or drifting. And then the loss of the gingival periodontal ligament fibers and alveolar bone is detected as clinical attachment loss by assessment of the dentition with a probe as measured from the CEJ. So we're going to go into how exactly you calculate the clinical attachment loss. The CEJ is used on most measurements as your base for your measuring because it's a fixed point on the tooth. The gingival margin, the attachments of the tissue, the alveolar bone, all of that varies in height based on health or disease, but the CEJ stays the same place on the tooth throughout life. So localized or generalized inflammation, localized may involve one site on a single tooth or several sites on a tooth or several teeth. Generalized may involve the entire dentition. Contributing factors may be modified by factors that increase the susceptibility of a patient to disease. So smoking, diabetes, the two biggest ones you're going to encounter probably are smoking and diabetes. But even intraoral factors such as tooth crowding, restorations, they can all contribute to disease. Symptoms. With periodontitis, there's usually no pain. A patient may notice some bleeding on brushing, they may notice spacing between their teeth, or they may even notice loose teeth. They may complain of food impaction, sensitivity to hot and cold due to exposed roots, or dull jaw pain from the bacteria. So usually a periodontitis patient will have noticed some of these symptoms, but they can't connect them up to what is causing the symptoms, and so they ignore the symptoms. Bleeding and brushing, you'll always hear patients say, well, my teeth or my gums always bled when I brush. So I always kind of, when I'm trying to drive the point home, I always would say to a patient, well, let's take, for example, your finger. If you woke up every morning and your finger bled for no reason, would you ignore that? Would that be considered normal? So bleeding when you brush your teeth is not normal. Now, it doesn't mean it hasn't been going on for a long time, but it's not normal. May notice spacing between teeth or loose teeth. Teeth will drift when the bone support is lost, or they will become mobile as they have less supporting structures. Onset of periodontitis. So gingivitis as a risk factor for periodontitis. Plaque-induced gingivitis precedes the onset of periodontitis. So all periodontitis is preceded by gingivitis, but not all gingivitis is preceded or results in periodontitis. The age. Age of onset can occur at any age, but more common in adults, and the disease severity increases with age. As a patient continues to age, there are a lot of changes that occur, but the severity of their disease, there's several reasons why the severity becomes worse with age, and we'll explain those later. Patient education. So since periodontitis is not usually painful, the patient may notice these other signs like the red and swollen gingiva, bleeding, bad taste, bad breath. Those are all things you can kind of ask the patient about when you're trying to educate them about periodontitis, because most of the time they've noticed some of these things. They just haven't connected the dots. Characteristics of periodontitis, it usually occurs in adults. It's initiated by biofilm. Bone loss may be seen on the radiographs. Usually it progresses slowly over time. It may be localized or generalized, and it can be modified by other factors such as smoking, diabetes, restorations. It can even be modified by attitudes of the patient. And progression of periodontitis. So the extent of the destruction. Extent is the distribution of the disease throughout the entire dentition. So when you're looking at periodontitis, one of the things you want to evaluate is the extent of the destruction. Is it localized or is it generalized? So localized usually, basically it involves less than or equal to 30% of the teeth are involved. So about a third of the mouth would be or less would be affected by periodontitis. Generalized may involve, well, it's going to be more than 30%. So most or even the entire dentition can be involved. Disease progression. So the progression in untreated periodontitis is usually a continual and slow process, which is part of the reason why it's hard for patients to understand it, because it's a slow moving process. It doesn't present itself with a lot of signs and symptoms. It's not painful. They don't know they have it. And so it's very hard to educate a patient on periodontitis because they don't even know they have it. It goes through periods of remission or exacerbation that may occur. So when we say it progresses slowly, it can have periods where it goes into remission, so it doesn't continue to progress. It just kind of on an upward curve, it flatlines. And then exacerbation, so then it curves back up. So it starts to recur again. In limited numbers of individuals, there is rapid progression. So it can progress rapidly, but that's more limited. Tissue destruction does not affect all teeth evenly. So that's why you can have some localized, some generalized. That's why it's important that we probe every tooth and that we probe 6 spots on every tooth, because it doesn't progress evenly. It can even be site specific. So you can have periodontitis on 1 or 2 teeth. Rapidly progressing disease occurs more frequently in the interproximal areas with heavier calculus deposits. So what's your desired outcome of your therapy to stop the progression of the disease and to prevent further attachment loss? So oftentimes when I ask students, what's your desired outcome? They'll say to remove plaque or to remove calculus. Well, to stop the progression of the disease and prevent further destruction is the most desired outcome. And the predictor of future disease, the biggest predictor is their history. What's the patient's history of disease? If the patient had periodontitis and has stayed stable for 15 years, but you're measuring a few 5 and 6 millimeter pockets, that's different than a patient that's had periodontitis for a year and has 5 or 6 millimeter pockets. Before and after periodontal therapy. So these are some pictures. This is case 1, And if you look at the before and after, it doesn't look a whole lot different. There's some tissue color changes, but visibly, there's not a whole lot of difference. So now you can see why a patient would have a hard time recognizing periodontitis. Case 2, it's a little bit more noticeable. You can see that they have, in case 2, some red gums. In case 2 after, the redness is gone. So things look like they've healed a lot better. Therapeutic endpoints, elimination of microbial etiology and contributing factors that perpetrate inflammation. So what that basically means is remove bacteria and anything that's contributing to it. So if the patient has an area where you can eliminate the problem, maybe it's a restoration overhang, and you're going to recommend that the patient go and have the restoration replaced. If it's something like crowded teeth and you've recommended an orthodontic treatment, but the patient is not going to do orthodontic treatment, then going through and giving them home care, good home care instructions is the next best thing. Preservation of state of the teeth and the periodontium in a state of health, function, and stability. So we want our patients to be healthy, we want them to be able to function, and we want it to last. And we don't want it to come back or recur. Different forms of recurrent forms of periodontal disease. So we have periodontal disease that is recurrent is the return of destructive periodontitis that had been previously arrested. We have two terms here. We have recurrent and we have refractory. They mean two different things. Recurrent is the return. So the patient came in, they had periodontitis, they had scaling and root planing, maybe they had some surgery, good oral hygiene instructions, and they got better. And then 2 years from now, the disease reappears and they have red bleeding gums. Maybe they've had a health issue in between, or maybe they had broken their arm and they can't brush their teeth effectively and floss, or whatever the case might be, but the destruction returned. Refractory is a different animal. Refractory is the patient that came in, had periodontitis, you did scaling or root planing, they come in for their reeval, they still have bleeding, probing depths above normal, they're still showing what we call signs of active disease. Bleeding on probing, a lot of inflammation, red gums, plaque accumulation, etc. So that you go home and you reinforce good home care. You teach them all kinds of things to do at home, and you have them come back in another month for another cleaning. And they return in another month, and everything looks good. I mean, when I say everything looks good, they've increased their home care. They got a water pick. They got an electric toothbrush. They floss twice a day. They use their water pick daily. They do everything that they possibly can. And they have no plaque on their teeth, but they still have pocketing. They still have bleeding. That's what we consider a refractory form. They never stabilized. It just kept going. They still keep having disease. This is a picture of the refractory form of periodontitis. So refractory forms can continue on and bone loss will continue to occur. Staging and grading. So I showed you the other day in chapter 4 the staging and grading chart. So we learned a little bit about how the chart works, but we're going to talk about it in a little more in depth now. A patient is a periodontitis case if they have interdental clinical attachment loss detectable at 2 or more non-adjacent teeth. So let's break that down. Interdental clinical attachment loss. So when we take our probe readings, we go mesiobuccal, and then we go on the direct buccal, and then we go on the distal buccal. And then we go around and we go distal lingual, direct lingual, mesiolingual. So we take our 6 probing readings. The mesials and distals are the interdental clinical attachment loss that we want to pay attention to. The others are considered to be recession. And remember, periodontal breakdown occurs first in the interproximal areas. Inflammation and gingivitis occur first in the interproximal areas. So why? Mainly because patients don't floss their teeth or do anything to clean between their teeth on a regular basis. And then detectable at 2 or more non-adjacent teeth. So we don't want it to just be on 1 tooth or 2 teeth. It's got to be non-adjacent teeth, teeth that don't sit next to each other. Or facial and lingual clinical attachment loss of 3 millimeters or more with pocketing greater than 3 millimeters, detectable at 2 or more teeth. So if you have facial or lingual clinical attachment loss, it has to be 3 millimeters or more with pocketing greater than 3 millimeters, detectable at 2 or more teeth. So in other words, the clinical attachment loss has to be more than just like 1 millimeter along the facial surface, because that would probably be just recession. Attachment loss cannot be due to non-periodontitis causes. That's the #1 rule that you need to keep in your mind. The attachment loss cannot be due to non-periodontitis causes. So gingival recession from toothbrushing, dental caries extending to the apical to or apical to the CEJ. In other words, if you have dental caries going underneath the gum line and onto the root surface. Presence of clinical attachment loss on the distal aspect of a second molar associated with the extraction of a third molar. So they took out the molar and the tissue behind it didn't heal. Then you have endodontic lesions. Endodontic lesions that drain up through the gingiva. They'll destroy the ligaments in the bone around a tooth, but that's considered part of the endodontic destruction. Or a vertical root fracture. So if a patient fractures the root from the top to the apex, those root fractures are going to form a deep pocket and a lot of infection if they're not taken care of. But that's not considered periodontal disease. Pathophysiology related to periodontitis is the study of pathologic manifestations of periodontitis on the periodontium, explaining the processes within the body that result in the signs and symptoms of periodontitis. 3 forms of periodontitis based on pathophysiology are necrotizing periodontitis and periodontitis as a direct manifestation of systemic diseases. And then we have periodontitis. So based on the pathophysiology, or as we said, the study of the manifestations of periodontitis. So stress can be a factor in necrotizing periodontitis, as well as damaging bacteria, systemic diseases that can contribute, such as diabetes. 4 stages. So stage at presentation of periodontitis case is defined by the disease severity and the complexity of management. So how bad is the disease and how hard is the disease going to be to manage? Stage 1, I'm not going to read through all of these, but stage 1 would be like a slight case of periodontitis. Stage 2 is a more severe stage. It's a more established stage. It's a little bit harder to manage. And then stage 3 and stage 4 are both considered severe cases. They're difficult to manage. They have advanced bone loss. They can have previous tooth loss. They can have mobility, furcation involvement, clinical attachment loss, probing depths, furcation involvement, all of those different things. So stage 3 and stage 4 are really only differentiated, or mainly differentiated, by their complexity of management. So they both have lots of clinical attachment loss, teeth missing, radiographic bone loss, but the complexity of management, how deep are the pockets? How much bone loss do they have? How many furcation defects do they have? What about drifting and things like that? We have grades. We have 3 grades, A, B, and C. Grades are an indicator of the rate of progression. So you're going to stage it and you're going to grade it. They chose this because it was like staging and grading is what they use in cancer. And most patients can have some experience with somebody with cancer, and they can acknowledge, number one, cancer is a disease. Number two, they know that when they stage and grade cancer, it tells them how bad is the disease. So they've chosen this because it does help patients to understand the disease process a little bit better. So when we say you have periodontitis and it's a stage 3 grade B, it catches a patient's attention and it gives us a more direct, more black and white of a feeling of what we're taking some of the guesswork out of it. So before we used to say slight, moderate, mild, moderate, severe, slight, moderate, severe, and that's kind of a judgment call. What you say is moderate might be different than what I say is moderate. But when we're looking at staging and grading, I mean, if they have interdental clinical attachment loss of greater than 5 millimeters, and they have radiographic bone loss that extends to the middle third of the root, and they have 4 or fewer teeth, that's a little bit more measurable than just saying, I would say it's moderate. So we determine the likelihood of clinical attachment loss progressing, and then we base on direct evidence using longitudinal observations, and we based on indirect evidence on assessment of bone loss. So grade A is a slow rate. There's no evidence of clinical attachment loss or radiographic bone loss over a 5-year period. We don't always have 5 years of radiographs available. So there's a backup plan for when you don't. In fact, there's a lot of times you're going to see a patient for the first or second time, and maybe they haven't been to the dentist in 10 years. Maybe they didn't have radiographs taken for a long time. I mean, there's a lot of reasons, and in clinic especially, there's a lot of reasons why we won't have radiographs available. Heavy biofilm deposits with low level of tissue destruction, and then modified by non-smokers and normal glycemic patients. So in other words, patients that smoke or have diabetes. Moderate rate of progression, the patient will have less than 2 millimeters of clinical attachment loss. I'm not going to read all of this, but what I do want you to notice is that down here on the smoking and the diabetes, the test for diabetes is called an HbA1c, and doctors like it to be 7% or less, or 7.0 and less. So if a patient is stable, they will have an HbA1c of less than 7. If they're not stable, it'll be higher than 7. Most diabetic patients will know their A1C. If they're are a heavy smoker or smoke more than a half a pack a day, or they have an A1C of greater than 7, they are automatically at a higher rate of progression. Your periodontal diagnosis is your confirmation that a patient is a periodontal case, and it should include clinical attachment loss at 2 non-adjacent teeth. It should tell you whether it's periodontitis or if it's a necrotizing periodontitis or a manifestation of a systemic disease, or is it just periodontitis. 99.9% of the time, it's probably just going to be periodontitis, and we're going to stage and grade it. The description of aggressiveness of disease by providing the stage and grade. So when you're making a periodontal diagnosis, you might say generalized periodontitis, stage 3, grade B. If you don't have radiographs available, we will usually just go with a grade B. And then from the grade B, we look for evidence of either an A or a C. So we'll go with, they have a normal amount of progression or rate of progression, unless we see no, they've gone 10 years and haven't lost really any bone, then that would be a slow rate. Or if you go and you go, oh, well, it looks like they don't have a lot of bone loss. However, they smoke 2 packs of cigarettes a day and they have uncontrolled diabetes with an A1C of 9.0. So I'm going to guess that with those two things together, they're going to progress rather rapidly or at a grade C. So clinical findings, these are some examples. It says case example, stage 1, grade A periodontitis. This is what you might see on a patient that has a stage 1, grade A periodontitis. So this patient has interdental clinical attachment loss. If you open your textbook to page 135, you can take each of these clinical findings and you can pinpoint them on the chart. This is the same chart that we have available for you to use in clinic. So when you're in clinic and you're going to stage and grade a patient, you're going to want to get this chart. We have an example of what a stage 3 grade C would look like. Here's the another stage 3 grade C. And then here's the stage 3 grade C again. And these are all different ways that a stage 3 grade C can appear to us clinically. So if you look at each of these examples, they are all slightly different with slightly different things, but they are all stage 3 grade C periodontal patients. And then this is an example of a patient that has stage 4 grade C. And you can see by looking at the list of complications that the stage 4 grade C patient has, that they are more advanced and they are going to progress more rapidly because of the smoking that they do. And this one's a grade 2, stage 2 grade B. And this one's a stage 3 grade B. So look those cases over and we'll discuss them in further detail during our lecture time. And that concludes our chapter summary for chapter 7.